I want to introduce Dr. Siobhan Phillips, who's going to talk to you about physical activity promotion for cancer survivors. So Siobhan Phillips is an associate professor in the Division of Behavioral Medicine in the Department of Preventive Medicine at Northwestern University Feinberg School of Medicine, and she's also the director of physical activity promotion of the Lurie Cancer Center's Cancer Survivorship Institute. Her interdisciplinary research is focused on understanding the determinants and outcomes of physical activity participation, developing and testing innovative physical activity promotion interventions, and the translation of this research into practice with an emphasis on cancer survivorship. Ultimately, her work aims to mitigate cancer treatment-related side effects, reduce early mortality, prevent or delay the onset of morbidity, and improve physical and cognitive health and well-being. Thank you.
Thank you for that introduction. So today I'm going to talk about my work trying to optimize physical activity interventions for the real world. So it's kind of after, following rehab, this is people that don't need rehab, we're trying to get them active. So it's kind of me and Anne-Marie were talking about, there's kind of like this baton handoff. So people that are able, that don't necessarily need rehab, might be ready for physical activity. And so talking a little bit about that. So she went over this, we have a growing population of cancer survivors. There's many negative treatment-related side effects that don't necessarily diminish post-treatment. Some persist, some may even have a delayed onset. Compared to non-cancer controls, cancer survivors have increased morbidity, frailty, functional limitations, risk for primary, secondary cancers. They experience decreased quality of life, decreased physical and cognitive functioning, psychological well-being, and aerobic capacity. And so physical activity is one potential intervention or one potential behavior that may actually help improve a lot of these side effects. It's been associated with improved psychological well-being and quality of life, improved muscle mass and bone density, physical and cognitive functioning. It's associated with a decreased risk of chronic disease and a decreased risk of negative treatment-related side effects. And there's emerging observational evidence that suggests it may actually increase survival in some cancers and reduce the risk of recurrence, second cancers, disease progression, and mortality. And because of all of these benefits, there's just actually recent recommendations that came out a couple weeks ago, but it's recommended that all survivors engage in physical activity. The old recommendations were consistent with the public health recommendations of 150 minutes per week of moderate intensity physical activity or 75 minutes per week of vigorous aerobic activity, and then 2 times a week of full body strengthening exercises. The new guidelines that just came out, they were actually really designed to try to target specific outcomes. And so they looked at 16 different outcomes and said that at a minimum, in order to see improvements in these outcomes, survivors need to engage in physical activity of moderate intensity aerobic activity for at least 30 minutes, 3 times per week. So it's a little bit lower than the public health recommendations, but this is kind of like the minimum to see a benefit. And then along the same lines, 2 times a week of full body strength training exercises. But in general, the recommendation is that survivors move more and sit less throughout the day, and that some physical activity is better than none. So even if they can't get to these goals, to these targets, that even doing something is better than nothing. And to try to avoid inactivity and return to normal daily activities as soon as possible following diagnosis. However, what we see is that physical activity tends to decline post-diagnosis, and then after treatment ends, it tends to go up again, but never really returns back to baseline levels. And that up to 70% of survivors do not engage in 150 minutes per week of moderate intensity physical activity. So this suggests that while there's all these benefits, there's still a lot of work to be done to try to figure out how to get survivors to be more active. And before I kind of get into some of the studies we're doing, I want to talk a little bit about, what is driving the work that we're doing. So I've had 3 observations that kind of drive what we're working on now. And the first is that supervised physical activity or exercise is likely not the answer if we want to try to get a large number of survivors active. That seems pretty obvious, but most of the work that's been done in cancer survivorship to date is really these on-site intensive exercise interventions where they come to you 3 times a week, and the likelihood of that actually being translated to the real world is small because unlike rehab, we don't actually have coverage for exercise as part of insurance. So unlike cardiac rehab, things like that, we don't actually have any coverage for exercise prescriptions within oncology. The other thing is that, when we have people coming 3 times a week, it's really not sustainable in terms of a cost perspective since no one will cover it. But also, participants, they tend to not be ready to actually go into the real world. So when I was in grad school, I was part of a 12-month on-site intervention in older adults. And what we saw was, so this is self-efficacy, which is the belief that they would continue to exercise. You can see here that for 2 of the self-efficacy measures, or almost 2 of the 3 measures, that at the end of the intervention, they actually had lower self-efficacy than they did at the beginning. So they had come and exercised with us 3 times a week for a whole year. I woke up at 5 a.m. to exercise with them. And at the end of the intervention, they really weren't ready to continue on. And even more disturbing was that we had another exercise intervention start about 9 months later. They had to be inactive for 6 months, and we had all these participants that were like, well, I haven't exercised since I was at your program that last day. And so I had this realization that, maybe this isn't the answer in terms of actually trying to change behavior in the long run. And then the other observation I had is that, one size may not fit all. So when we typically look at our interventions, we look at mean level changes, and we say, okay, great. Exercise, physical activity increase, the program works. But what really happens is that, for some people, it might not work quite as well. They might not show as great of increases in physical activity. Others might, actually do better than the mean. Some might actually not change their activity at all, and some might actually decline. And we tend to try to find an intervention that will work for everyone, but the reality is that there's probably not a one-size intervention that will work for everyone, and that, rather than trying to find this unicorn, maybe embracing some of this heterogeneity in response could actually help us figure out what would work better for more people. And then kind of the final observation is that there's really a gap in the exercise literature, the exercise oncology literature, between research and practice. And so a lot of the work that's being done in research labs that are showing these great effects for physical activity on cancer outcomes is really, they're not ending up, it's not ending up getting translated into the real world. It's ending up on the bookshelf. And a lot of this has to do with the design of the studies. A lot of them are efficacy trials because we're a relatively young field, so trying to establish the benefits. But I think we're at a point now where we can kind of move beyond that and try to figure out how to actually design programs that might be more sustainable. And there was a recent review that came out of about 30 studies that looked at distance-based interventions to promote physical activity, and they found that they had a small to moderate effect, but the conclusion was that most of them had small sample sizes, and that there really wasn't any intervention that was ripe for translation. And so this suggests that there's still a lot of work to be done to try to figure out kind of how we go beyond these supervised trials and might actually have a chance to be more well integrated into cancer care. And so my lab is using a lot of technology to try to help kind of bridge this gap. And why we're using technology is that it has greater reach and scalability, and it's less burdensome on patients. So, they will come to the cancer center to get treatment, but a lot of times they will travel very far to do that. They're likely not going to travel an hour in Chicago traffic to come exercise with me for 30 minutes. And so trying to think about how we can reach more people and have it be less burdensome on them. I mean, some of you parked here this morning. It's not an easy thing to do. It can be stressful. And so trying to think about how we can reach them better. We're able to remotely monitor them, so if they're wearing sensors, we can kind of see how they're doing, and we don't have to, they don't have to come to us for that. We have the ability to integrate physical activity data with other data streams, so I'll talk a little bit about how we're doing this, but integrating some of our sensors like Fitbits, Apple Watches into electronic health records, also looking at other contextual factors like GPS, heart rate, and kind of getting a better picture of what's going on. And this can actually help us facilitate tailoring a physical activity program, so to the individual and kind of what's going on with that. And what we've seen in the general population is that technology-based interventions have shown small to moderate effects in terms of increasing physical activity in the general population. So we assume that they would have an effect potentially in survivors as well. And so when you start to think about technology-supported interventions, features, this is a huge, long list of potential things that you could offer people, right? There's the standard educational information, which really isn't tech-based, but it's distance-based. Hand them a handout, give them information. There's coaching you can do from a distance, either through text or phone calls. You could put people, on teams using some apps. There's incentives. There's online group webinars. You can give them trackers. You can give them an app with a bunch of different features, text messages, exercise videos. There's a whole long list of potential things that you could give people, right? And what we did was, rather than kind of saying, okay, this is what we want to do, which is what the typical treatment package approach is, where you say, okay, I'm going to pick these 5 things, I'm going to put them in this intervention, and then I'm going to evaluate them and see how it works. We took a little bit of a different approach, or are trying to take a bit of a different approach, and seeing trying to figure out which components work, because in that typical treatment package approach, what you don't know, let's say you have a significant effect. So we say, oh great, our intervention worked, which is what we want to happen, obviously. We don't actually know which components are contributing to that effect, so did we need to do all of that? We don't know whether including one component affects the impact of another component. We don't know whether putting a high-cost component in there, the benefit of that actually offsets its cost. We don't know if we actually need to do all that, or there's one thing in that package that's actually kind of our active ingredient. And we don't really know how to make interventions more effective, efficient, or scalable. And then on the flip side, if we have a non-significant effect, so we find our intervention didn't work, we don't know whether any of it is worth retaining, whether potentially one component had a negative effect that offset the positive effect of another, and we don't really know what went wrong and how to do it better the next time. And so we're using an approach that's really been pioneered by Linda Collins at Penn State, and it's actually adapted from engineering. It's called the Multiphase optimization strategy. So it's a framework for helping us to try to optimize our interventions. It's an efficient and systematic way of doing that, to try to identify the most promising intervention components or component levels. And a component is really anything that can be reasonably separated out for study. So it can be things really anything. Phone calls, it could be retention strategies, it could be a Fitbit. And so most has these different phases. So the first phase is preparation, and that's really, kind of defining what you think the components to test should be. And then once you've determined what those components are, moving on to optimizing it and doing an optimization trial, which I'll talk a little bit about some of the trials we're doing. And then once you're done with that, you can see which components had an effect, and then identifying which components you think are the active ingredients, and then evaluating whether you think that you expect this to be sufficiently effective. And if not, then you don't just keep going. You kind of go back to the drawing board and think about, okay, well, what are some other components that might work? If you do think that you would expect them to be sufficiently effective, you move on to more of the traditional randomized control trial to test those intervention components against some type of control. And so it's still kind of in line with traditional research, but we're trying to actually optimize our interventions and make them more effective from the start, and not kind of the other way around. And as we're optimizing, you can think about things like cost and resources and optimize for those types of outcomes, so you can get programs that might work better in real-world settings. And so we have a project that we recently finished called the Fit2Thrive study, and we used most to develop this intervention. So we did both the preparation phase, where we actually interviewed survivors and providers and different community partners on what they thought would be useful in a technology intervention. And then based on those data, we developed our intervention components to test in phase 2. And we had the survivors engaged in that whole process. So they provided feedback they actually tested the app, they provided feedback on it, they gave us feedback on our text messages and all. They were really engaged in that process. And then we moved on to the optimization phase, where we used most to try to identify which components resulted in an increase in physical activity. And the idea was to try to build a more scalable intervention made up of components that were effective at increasing physical activity, but then as a bundled package cost less than $550, which is the average of what insurance covers for the diabetes prevention program and cardiac rehab. So we kind of settled in the middle there, thinking if this were to ever get covered, if we could develop a program that would be within that range. And we were trying to consider real-world implementation from the start. So we never actually required anybody to come see us, and this was a nationwide study. We used the Army of Women to recruit, so we recruited from all over the country, and didn't actually require them to ever come see us. So for better or worse. And so we were trying to really think about something that had high scalability. And so what we ended up with in terms of our components were our core intervention. So what everybody got, a Fitbit with a basic app where they could self-monitor their behavior. And then they were randomized to receive anywhere from 0 to all 5 of these components, because we're essentially comparing each component on to each component off. And those were a Fitbit Buddy, a deluxe app notifications, biweekly coaching calls, and an online gym. And I'm going to get into a little bit of details of what each of those things were. So the Fitbit and the Fit2Thrive app, that's a picture of it. Here they could actually track their behavior. They could, we set goals. We helped them set goals, gave them feedback on if they were achieving their goals. There were some educational materials in there, and this was deployed automatically when they downloaded the app. They could just, see all those things, and then once the group that got the deluxe app had some additional components beyond just self-monitoring, in terms of what we called Fit News, where we posted twice a week on something related to physical activity and cancer. One was a survivor spotlight where we highlighted somebody who'd successfully been active, and then another was where we highlighted research in physical activity and cancer survivorship. And then they also had the ability to kind of set these daily challenges against themselves, these daily step challenges, and to be able to actually see if they achieve those. And then the other component, coaching calls, basically we called them bi-weekly. Every other week they got a coaching call. We talked them through kind of their progress in the intervention, helped them set goals, helped them problem solve if they weren't meeting their goals. And the calls lasted about 10 to 15 minutes. And then individuals who got app notifications or text messages, they actually got them, they were tailored around their progress. So they'd get feedback on, if they met their goals or not, they'd get a text message right away. And then they'd also get feedback, they'd also get these messages kind of about building their self-efficacy and, the benefits of physical activity to kind of just remind them throughout the week about being active. And then the online gym, they got a weekly email with a schedule, and they had access to exercise videos. All of them were primarily aerobic based, so they didn't need any equipment. And we gave them a whole program on recommending how to use those videos. And then the Fitbit Buddy, individuals picked somebody from their personal life to be their buddy, and we gave that person a Fitbit. And then we sent both the buddy and the individual and the participant weekly emails that were automated about how they could help support each other. And so we screened 419 women for the study. The Army of Women was a really great recruitment source. We were able to recruit in about a year. And we randomized 269, and we had really good retention. So we retained a little over 90% at 24 weeks, and our primary outcome was physical activity, and we have physical activity data on about 82% of participants at both 12 weeks and 24 weeks, because this was a 12-week intervention. Our sample looks pretty similar to those for most breast cancer survivor studies. It's a little bit on the younger end at 44. Most of the time in most exercise interventions are right around 55, so we are a little bit skew a little bit younger. But we had 46 states represented. In general, they were overweight, a little more towards the high education, high income side, had early stage disease, almost all had surgery, most had radiation, and most had chemotherapy. And on average, they were 3 years since diagnosis. The criteria were that they had to be at least 3 months post-treatment, but within 5 years, so kind of right in the middle of that range there. And what we found in terms of app kind of preliminary feasibility, acceptability of this study, overall, people liked the app, and the app content. They felt that the staff was adequate and offered adequate support. So in general, they were pretty satisfied or very satisfied with the intervention. And when we look at physical activity results, we found that physical activity over the course of the initial 12 weeks increased by about an hour per week, or 8.5 minutes per day, which is similar to what we've seen in more intensive on-site studies. And we also saw a 21% increase in the number of women who were actually meeting that 150-minute per week goal. And like I said, this is similar to studies. There was another study that had almost identical results for a 12-week intervention that required 9 on-site visits, supervised individual visits, and 3 phone calls over the course of that intervention. So that made me feel pretty good that we had a much lower touch intervention and we're seeing similar effects. But when we actually looked at the components, we did not see any significant difference by components. So everybody increased their physical activity, but people in the on condition didn't increase any more than the people in the off condition, at least from a statistical standpoint. And we're still analyzing these data, but it's perplexing a bit to say that, nothing seemed more effective in the on versus the off. And so, of course, we think, well, maybe, people just didn't use what we gave them, and maybe that's why we're not seeing these effects. But in terms of the core intervention, people wore their Fitbit on 95% of the study days, which is pretty good. 67% reported using the app 5 to 6 times a week. We actually have objective data that we're still working through on app usage. The online gym did have lower adherence, so only about half reported using it more than 1 time a week. About 40% said they never used it, which was a little disappointing. And then we had about 60% of our app notifications marked as read. And to be marked as read, they had to actually click on the message. They could have read it without actually having it marked read, so it's actually probably a little bit higher than 60%. We completed 99% of our support calls. 88% of people reported discussing the intervention with their buddy at least 1 time a week, and 60% reported at least some support from their buddy for exercise each week. And we're still working through the data on the Deluxe app. But in general, other than the online gym and the buddy did have lower compliance, but overall, the compliance was pretty good with using our components. And so, we're starting to think about what these data mean and what, our next steps are. And, from our preliminary work as part of the study, we know that survivors, at least breast cancer survivors, are interested in tech-supported physical activity interventions. We, proved that we can deliver a physical activity intervention completely remotely, which I think, is important because there's some people that would say, oh, they have to come see you. And that, our intervention increased physical activity. We don't exactly know why yet. And we're working on figuring that out. So we don't know, why on level was not more effective than the off level. We don't know if there's no effect for all participants in the study, right? So there might be some heterogeneity in terms of there might be some people who some of these components did actually work better for. So doing some analyses to kind of figure out if some of the components work better for different individuals. We haven't looked at the 24-week data, so we don't know if maybe some of the components actually contribute to people maintaining their physical activity behavior in the long run. And then we also have other outcomes in our study in addition to physical activity. So we have data on inflammation, cardiometabolic biomarkers, as well as patient-reported outcomes, such as fatigue, depression, anxiety. So we'll be able to see, too, if potentially, some of these components have an effect on these other outcomes. And so as we start to think about future directions, we're starting to think about, should we be refining some of the components we have? Because everything was very low touch. So this was funded by a K Award, which is a very small, low budget study. So thinking about, could we enhance some of these components? Or are there other things we should be thinking about to test? And then, maybe it is just that the app plus the Fitbit worked well enough and these other low touch things aren't going to add much to it. And so thinking about, should we be looking at testing just our Fitbit and our app? Because really, if that works, it's much lower cost and a much, more likelihood to get taken up and actually translated than if we have to add all these other things onto it. So it's not really necessarily a bad or, it's actually a good story to some extent. And so thinking about, could we test this app versus just, people getting nothing and kind of their standard of care or them getting this educational materials. And then thinking about how we can integrate some of this into oncology care. So, could we have it where people who report low levels of physical activity would be given our app to use and, see if that actually helps them increase their activity so that they have, we do have a resource to offer them that doesn't currently exist. And then also thinking about more of a stepped care approach. So kind of this along the same idea that, maybe the app works, just the app and the Fitbit works for some people, but for other people, they might need more. And so stratifying people so that, the people that don't need more, we don't waste our resources on, but the people that do, we can invest our resources in them and give them what they need. And so kind of based on these data, we have our preliminary data on feasibility and acceptability from Fit2Thrive. We have 2 additional studies that are just actually starting up. The first is Fit2Thrive MB. It's funded by NCI, and as part of this, it's a small pilot randomized control trial. So we are testing a revised version of the Fit2Thrive app, where instead of focusing on getting 150 minutes per week of physical activity, we're actually focusing on just increasing any activity through steps. And we are trying to personalize it a bit more and having people rate their symptom burden at the beginning of the day and taking that data and combining it with whether they've achieved their previous day's step goal to help them then give them a set of 3 different goals to choose from, but choose a goal that they feel is appropriate for them for that day. And so it's a little bit more individualized than Fit2Thrive was. And then we're also created a message board where participants in the study can actually see others' progress and actually talk to each other and post things, and we will be moderating that and posting about once a week, and they also get weekly phone calls. So this is kind of more on the intensive side, but trying to see why we went this route for metastatic breast cancer survivors was that there really isn't a lot of interventions for them right now, and those that have been done have been on-site intensive interventions that have been deemed not feasible. And so trying to see if we can do something more distance-based that's more tailored and see if that's more feasible for them. And then we would kind of move on to more of the optimization. And then the other study we have funded that we're just starting up is we actually are integrating the Fitbit into the electronic health record. And this is called a non-responder study. So instead of it's kind of that idea of stepped care. So basically everybody's starting with what we call a minimal intervention, which consists of the Fitbit that's integrated into the electronic health record, and they'll get weekly emails on their progress. And then if they actually go into the clinic, because these are survivors, so they're coming at different interval schedules, their provider will get a message 24 hours before they come into the clinic to prompt them to talk about physical activity with their patient, and they'll actually be able to see all their physical activity data in the patient's record. And so we're starting that in breast and endometrial cancer survivors. If they're doing fine with this minimal intervention, we just keep them going on that minimal intervention. If they're not, so we'll look at them every 4 weeks. If they're not responding, then we'll actually randomize them to get these bi-weekly coaching calls or an enhanced version of the online gym where they're getting these toolkits, and we'll be doing more to kind of make sure people are actually using it. And so that will help us just determine, kind of who this minimal intervention works for, and then if it doesn't work, what do we need to do? What works better in terms of giving them more? And so this will get a little bit more at, kind of this stepped care approach, and we're trying to integrate that more into the clinic than our previous interventions. And so just kind of wrapping up here, this is one of my favorite quotes: "The significant problems we face cannot be solved by the same level of thinking that created them." So physical activity behavior change in cancer survivorship is complex. There's a lot of factors that go into whether or not someone can be active, how to help them become active. And unlike in mice, you turn off the light and they start running on their wheels. That doesn't happen with people. And so trying to figure out, how to get people to be more active, how to integrate this into care, how to help them overcome their barriers. It's a really complex issue, and especially when we don't, we're not mandated. So, trying to figure out how we can offer these services and help people is increasingly complex. And this is my final slide. And there was so alongside the activity guidelines, there was a plan for how to integrate physical activity into oncology care. That was a separate paper published by Katie Schmitz and others. And they proposed this idea of, they didn't have monitor in there, kind of the old idea of assess, advise, refer. And so the first part is assess, see if they can go do exercise or if they need to be referred to rehab. If they are capable of doing exercise, then advising them on the guidelines so they have a little worksheet you can hand to them, and referring them to community programs. And there's a whole new website that's been developed where you can actually search community programs as part of the ECSM. I would argue that, even beyond that, so in the red is kind of where I think we also need to go, is kind of integrating more data on self-report data and sensor data into the electronic health record, because we don't have physical activity as a standard assessment. We don't have, we don't have anywhere to really refer patients to other than community programs, and keeping abreast of all those and the changes in them is a lot of work. And we don't, you can refer people to nutritionists, but there isn't an exercise physiologist on staff. So I would say, trying to integrate somebody who has some exercise knowledge as part of supportive oncology is extremely important. And then thinking about, beyond just community programs, because some people don't like to go show up places, or there might not be a community program in their area, is thinking about potentially like tech resources and other resources where people can use those and even connect to other survivors to become more active. And then, of course, trying to connect all of this to the survivorship care plan so that we can ultimately improve health and disease outcomes in survivors. And so with that, I'm just going to acknowledge all of my collaborators and funding agencies who support my work. I didn't say this at the beginning, but I don't have any disclosures, so thank you.